Hello everyone, my name is Brian Lebo. I'm going to talk to you a little bit about asthma today. So what do we know about asthma? It's one of the most widespread diseases in the US. About 10% of children aged 5 through 17 are affected. There's an increased incidence lately in non-Hispanic blacks, obese children, and children from low income as well as urban areas. Globally, 300 million people have asthma. Genetic and environmental factors play a role in the disease, and death can result if left untreated. However, morbidity is on the decline due to recent treatments. Asthma pathophysiology. Asthma affects different areas of the respiratory tract. It infects the trachea, the bronchi, and the bronchioles. Bronchiolar inflammation and airway constriction cause the symptoms that we see with asthma attacks. Inflammation of the airways is mediated by mast cells, eosinophils, T lymphocytes, macrophages, neutrophils, and epithelial cells. Allergic and non-allergic asthma exacerbations include airway infiltration by T helper cells. These T helper cells then secrete cytokines. The cytokines result in stimulation of mast cells, eosinophilia, leukocytosis, and production of IgE. More into asthma pathophysiology. We know that disease progression and severity can lead to permanent airway changes. It is reversible, asthma and its exacerbations, but it can lead to permanent changes. Some of these include hypertrophy and hyperplasia of smooth muscle, an increase in mucus production, edema or swelling, thickening of the subbasement membrane, and proliferation and dilation of blood vessels. We know that bronchoconstriction is the main cause of airway symptoms in asthma. The airway becomes hyperresponsive due to inflammation. Bronchoconstriction results from IgE, mast cell degranulation, and the release of histamine, tryptase, leukotrienes, and prostaglandins. This bronchoconstriction leads to an increased heart rate and an increased respiratory rate. The body is compensating in this regard, trying to keep its tissues and organs perfused. The patient will begin to experience tightness in the chest, wheezing, dyspnea, dry cough, and a long expiration period. So asthma and genetics. Both factors, environment and genes, play a role in asthma development and its exacerbations. Over 100 genes have shown to have ties to asthma. However, one specific gene is unable to explain most asthma cases. The susceptible genes fall into 4 categories with relation to innate immunity and immune regulation, Th2 cell differentiation and effector functions, epithelial biology and mucosal immunity, and lung function, airway remodeling, and disease severity. Asthma in the environment. So studies have shown that people with similar genetic backgrounds have different incidences of asthma based on geographical location. They did a study of people of Chinese descent with similar genetic makeup. They studied Chinese people who lived in Hong Kong and in Canada and compared that with Chinese people who lived on the China mainland. And there was a higher incidence in the Chinese people who lived in Canada and Hong Kong. Data has also shown that the same polymorphism can lead to asthma in one place and not the other. A long time ago, a study was done before the wall came down in Germany. They compared similar genetic makeup of individuals in West Germany to East Germany. The individuals in West Germany had a higher incidence of asthma and its exacerbations. Continuing on with asthma in the environment, there are many environmental factors that can lead to asthma exacerbations. So some of these we know are mold, pets, dust mites, rodents, pollen, and fungus. We also know that air pollution and tobacco smoke are 2 huge ones. So with air pollution, this can be related to traffic-related emissions, and if you remember from earlier, we have a higher incidence of asthma in higher urban areas where you have more traffic-related emissions. You can also have tobacco smoke causing asthma exacerbations. It's a big trigger, one of the most common asthma triggers. And we know that environmental factors cause epigenetic changes that aid in the function of asthma susceptibility genes. So signs and symptoms. When no attack is occurring, the patient has no pulmonary symptoms at all. They have normal pulmonary function. You're not seeing anything until an attack occurs. When the attack does occur, some classic symptoms you might see are chest tightness, expiratory wheezing, dyspnea, dry cough, and a prolonged expiratory period. You're going to see increased respiratory rate and increased heart rate, as I said before, the body's compensating. When it gets extreme, you can also see some accessory muscle use. This is seen very often in kids. Then you'll also be able to hear inspiratory as well as expiratory wheezing during more severe exacerbations. No stethoscope needed for these. You can hear them from across the room. They also might be sitting in a position that tries to open up their airways and get them a little more air. So this would be the tripod position. They could be sitting on the edge of the gurney with their hands on their knees, kind of hunched over, just doing everything they can to open up that airway as much as possible. And in real extreme cases, you might not hear any airway sounds at all. This is a medical emergency and possible need for intubation. So how do we diagnose asthma? Good history and physical, of course, put together with the physical symptoms. We also want to look at parenteral history, especially with the children. You're going to look for increased IgE and eosinophil levels. And you're also going to perform pulmonary function tests, peak expiratory flow tests, and spirometry. And in extreme cases, you might draw some arterial blood gases. So, with asthma, CDC performed some studies that showed from 2002 to 2009, $3,259 was spent annually by asthma patients in their care. This includes medications, inhalers, steroids, maybe an emergency visit to the ER, something like that. Prescription medications were the highest cost in this dollar amount. And then this number was staggering to me. In 2007, the national cost of asthma due to direct care costs and missed productivity was estimated to be $56 billion. It's a lot of money. So in conclusion, we know that the pathophysiology of asthma remains only partially understood. Research continues. It's a complex disease with genetic as well as environmental ties. Lately, it's been looked at as more of a syndrome than a disease due to all the confounding parts that go with it. We know that it remains a burden to society and healthcare costs for hospitals and individuals. And we know that it can be life-threatening. It is reversible, but it still has the ability to cause morbidity. So, as providers, patient education is key. We need to keep them adhering to their medication regimens, their SABAs, their LABAs, their steroids, and we also need to teach them to avoid possible allergens. And here are my references. Thanks for watching.